So laparoscopic colorectal surgery, it was first performed by Geese in 1994, and of course sigmoidectomy is the first surgery which was performed, because sigmoid colon is the most diseased part of the colon, including cancer. Most common place is sigmoid colon. So that's why it was first performed. Anatomy is very important. Entire left side of the colon is supplied by the inferior mesenteric artery. An inferior mesenteric artery is a branch of abdominal aorta, and that is approximately 3 cm below the third part of duodenum. An inferior mesenteric artery, once it travels approximately 3 to 4 cm, it gives first branch, that is called left colic artery. After that, main sigmoidal trunk, which gives marginal artery. Marginal artery is supplying the sigmoid colon, sigmoidal flexure of colon. And then you have a superior rectal artery, which supply upper half of the rectum. The middle part of the rectum is supplied by the middle rectal artery, which is a branch of internal iliac. And then you have the lower rectal artery, which is a branch of pudendal. Left colic artery, most of the authors, especially the senior surgeons, old surgeons, they were not trying to disturb, because it is watershed area, and if you will clip the left colic artery, the blood supply of the splenic flexure of colon decreases, and then anastomotic ischemia can happen, and there is a chance of anastomotic leak. So you have to skeletonize it, and left colic, and then you can clip directly the main sigmoidal trunk. Colorectal surgery is of two types. One is for benign, other is for malignant. If you are doing for benign, it is not necessary to do all the medial approach first. You can combine medial and lateral alternatively. And you don't need to go to the root of mesentery and aorta, not necessary. Directly, because you don't need to remove the mesentery. Because like sigmoiditis, Crohn's disease, ulcerative colitis, mesentery doesn't have problem. So directly you can start coagulating, and medial, lateral, you can keep on going by the ligature directly. But if you are doing for malignant disease, then you have to remove the entire mesentery also, because main lymph node will be in the mesentery. In that situation, you have to go to the aorta and find out the artery, and you have to start from the root of the vessel, because entire mesentery also has to be removed, otherwise there will be no benefit. And in those situations, medial approach should be done first, and then lateral approach, just like how we do in the nephrectomy. Medial approach first, then lateral approach, or splenectomy also. Lateral approach of splenectomy only the French people they do. Otherwise, American and Asian, we do inferior and medial approach first. So here also, in colorectal, if you are doing for cancer, medial approach first. Because if you laterally mobilize it, all the colon will drop over the aorta. And then to dissect the great vessels of the inferior mesenteric, you have to pull it laterally and you will injure. So, left colic you will spare, and then main trunk you will clip. This is the inferior mesenteric artery, which originates 3 cm below the third part of duodenum. Anterior branch, of course retroperitoneal. Left colic artery, this is the splenic flexure of colon, which it's supplying, and then the main sigmoidal artery, once it comes, then it has a multiple joint, multiple branch, and those are called marginal arteries. And those marginal arteries supplying the sigmoidal flexor of colon. And this is superior rectal artery, which is supplying the rectum. These can be sacrificed without any problem. Now, vein doesn't follow the same course as artery. In most of the other organ, vein and artery goes together. But in the colon, vein goes completely separate. It doesn't go with the artery and it doesn't drain into the vena cava. So we have superior rectal vein, and after that these are the marginal vein, and after this marginal vein you have main sigmoidal vein, and then it drains into the inferior mesenteric vein. In case of vein, inferior mesenteric vein will join the splenic vein and then it will make portal vein. And then portal vein enter into the liver and then hepatic vein, and then all combine together and drain into vena cava. So vein has a different course. And when we sacrifice the vein, then we don't leave the left colic vein. We clip directly the inferior mesenteric vein. Because left colic vein is not one. In many situations it is multiple. Like here you can see 1, 2, 3, 4 left colic veins are there. So if you will leave one also and you will spare then also, and vein doesn't need to be take care because collateral immediately forms. Whenever you have decided the colorectal surgery, any colorectal surgery, then you should keep the patient kneel orally prior to the night of surgery, but fiber-free diet 1 week before the surgery. And in Indian condition, neomycin, cetirizole and antihelminthic also should be prescribed 1 week before the surgery. Fiber-free diet is required so that entire bowel lumen will remain collapsed, and antibiotics should be given, because in case of any leak, at least bacterial peritonitis will not happen. But if you will see the new literature, they say it is not necessary. They say that much strict mechanical bowel preparation is not required. That is bullshit. It is not necessary. Directly you keep kneel orally prior to the night of surgery and perform it. And some of them are against it, that if the bowel is completely empty, then chances of gaseous distension of the bowel is more. And completely empty bowel has a more chances of leak. So it is not necessary. But gaseous distension of bowel happen due to our mistake. One of the biggest mistake is task analysis. In any surgery, if you are performing colorectal, bowel, hysterectomy, endometriosis, one of the big problem is waiting for pneumoperitoneum. Like your patient is already intubated and you are still checking your WhatsApp. Your anesthetist will say that, sir, patient is ready. And you say, yes, I am coming. And then you are draping, you are washing your hand and putting your gown, and your nurse is setting up the trolley. Patient is intubated and 10-15 minutes is lapsed. Still your camera is not connected, still your insufflator is not connected. Bowel will get distended. So as soon as patient is intubated, within 2-3 minutes pneumoperitoneum should start. And once you will start pneumoperitoneum just after intubation, bowel will not distended. Because all these volatile anesthetic, especially nitrous oxide, distend the empty bowel, because in our peritoneal cavity there is a negative pressure. And that negative pressure is encouraging the bowel distension. And these volatile anesthetic agent, once they see that bowel is empty, it distends the bowel. But as soon as you will start pneumoperitoneum, now peritoneal cavity has a positive pressure. And against this positive pressure, bowel cannot distend. And your collapsed bowel will remain collapsed. Because now peritoneal cavity has positive pressure. So what does it mean? That as soon as patient lie down on the table, before intubation you should be draped, you should be gowned, everything you should be ready. And as soon as anesthetist has intubated, you should start painting. And within 2-3, maximum 5 minutes, start putting the various needle gas. And as soon as even 2-3 millimeter of mercury gas goes inside the abdomen, bowel will not distend. So problem is not with empty bowel, problem is our task analysis. That we are not taking care and we are spending time in the intubated empty bowel. So the new literature which say that bowel preparation is not required, that we don't follow in Asian country. We should do bowel preparation nicely. Because our patient diet is mostly the fiber diet, cereals. And in Asian condition, the colonic flora is very aggressive. And even you may get a roundworm also. You never know. So that's why neomycin is the best for gram-positive, gram-negative. Citronidazole for anaerobic without having metallic test, and antihelminthic should be given. And bowel should be nicely prepared. 8 days before the surgery, we should start fiber-free diet. 2 days before the surgery, we should give polyethylene glycol. That is Pegleg powder. Polyethylene glycol. And prior to the night of surgery, we can give one tranquilizer so that patient can sleep well at night. So this is, however, already I told you that this has debate, that we should give that much strict bowel preparation or not. Patient should be in the forward position, legs should be stirred up, and head should be 10 to 15 degrees down. You will stand opposite to the colon which you want to remove. If you want to do the surgery on the left colon, of course surgeon will stand on the right. And camera person will be left to the surgeon. And one assistant will be opposite, in between the leg. That is also surgeon. Why? To put the circular stapler, gun of the circular stapler. And scrub nurse will be here. थोड़ा सा इसको बंद कर दो हीटर को. Scrub nurse will be here to give the instrument to both first surgeon as well as second surgeon, to give the instrument to both. And this is how you will put the patient surgical team. Patient table is down, so there is a tendency that patient can slip up. So you must use shoulder support. Shoulder support is required for every pelvic surgery. Even in hysterectomy, prostatectomy, varicocelectomy, hernia, which we are missing. And when you buy any new OT table, they give you. An advantage is that once the patient is down, and if you have a shoulder support, patient will not slip up. This is shoulder support here. You can see that way patient will not slip towards the anesthetist, and this should be used. Even in hysterectomy, if you have a good shoulder support and you push the uterus cranially, then you can give more cranial traction. So here also in colorectal, shoulder support is must, so that patient should not slip down towards the anesthetist. When you do the left side of colon surgery, only one port will be left and all other will be right. And when you do right side, all the port will be left and only one will be right. One will be on the side. Why? Minimum 6 to 7 port is required. The reason being, from everywhere you should have triangulation. The problem of the colon is that even if you have to remove 2 centimeter colon, you have to mobilize it up to half of the transverse colon. Because colon is a fixed structure. It's not a mobile like a small intestine, you can pull it and join it side to side. Just like this carpet, it is fixed, it is pasted on the floor. And even if you want to move it 2 centimeter, you have to mobilize first the entire carpet. Otherwise, if you try, it will tear. So similar colon is attached with the paracolic gutter. And at the level of splenic flexor of colon, you have the phrenicocolic, splenocolic, linorenal, all these ligaments. So if you will not do proper mobilization, then you cannot approximate the edges. And there will be tension over the anastomosis and there will be leak. So mobilization part is the most important, and that's why laparoscopy is preferred. Do you know, none of the colorectal surgery is total laparoscopic. It is laparoscopic assisted. Because at the end, to remove the colon and to put the anvil, you have to open the abdomen. Now how you open, it is up to you. Most of the traditional method is giving one suprapubic incision. But new techniques are transvaginal, and even transanal extraction is reported. In that they take the proximal loop through the anus and then put the anvil and push it back. And in the female, posterior colpotomy, transvaginal, and then push it back. But anyhow you do, but you have to externalize. Either you externalize through the anus or vagina or by giving laparotomy. But anus and vagina is not accepted by every traditional surgeon because there is a high chance of infection. So suprapubic incision ultimately you have to do. And those are laparoscopic assisted. Total laparoscopic total is not possible. So for that reason, you have to, mobilization part is the most important part where laparoscopy has advantage. Because mobilization is very easy by laparoscopy compared to open. And you can have a triangulation everywhere. Ports should be introduced in such a way. Like here we will see, when you have to do the mobilization of transverse colon, telescope is here and these 2 ports will be used. And surgeon will stand in between the leg. When you have to do a splenic flexor of colon, telescope will be here and these 2 ports will be used. And surgeon will stand here. You can see still you have 60 degree. When you do descending colon, these 2 ports will be used and telescope will be here. Again you have a 60 degree. When you have to do sigmoid colon, telescope will be here and these 2 ports will be used. And when you have to do rectum, then telescope will be here and these two ports will be used and surgeon will go near the head. Because your target is from transverse colon up to rectum. This is not a fixed target like the cystic pedicle or hilum of the spleen or kidney. So due to the big target, you have to use multiple ports. And distance between all these ports should be 7.5, 7.5, 7.5, and one is supraumbilical and this is also in the region of, and distance between these two working ports should be 15 centimeter. Two working port. If the patient is elderly and you are using for malignant diseases, you have to stabilize the port by taking a bite on the skin and fixing the suture with the air inlet. Because cachexic patient, there is a tendency that cannula will become loose. Even in the animal dissection you might have seen that after half an hour, port doesn't hold. You are taking the instrument out, cannula is coming together. So the best way is to prevent it, that take a bite on the skin and wrap it around the air inlet and now it won't come out. Because if 2-3 times if cannula come out from the wound, it become loose. And now gas will keep on leaking. So we should stabilize it, the cannula. Because surgery may take 3-4 hour time. And gas will keep on leaking, and once the gas leaks, what happened? Dryness of the bowel and hypothermia. These chances are always there. And once the small bowel will become dry, there is chances of severe subacute obstruction or at least the very long duration paralytic ileus. And time to time after every colorectal surgery, bariatric also, time to time every 15-20 half an hour you should sprinkle some saline over the bowel loop, so that serosa of the bowel should never become dry. Optical port is supraumbilical. Why? Because you can see the para-aortic area and you can see for the lymphocellular lymphatic tissue all around the mesentery. If you are doing for the benign, then medial approach is first. Your start should be from the sacral promontory. All the bowel and omentum should be pushed towards the upper abdomen. That's why head should be down, because one of the big problem of the colorectal surgery is a small intestine. Because this small intestine keep on falling on your area of dissection. So all the small intestine and omentum you should push towards the liver. If patient is female, you should take a bite over the uterus and pull it and tuck it and hold it so that it will remain anteverted, so that you can see the pelvis. Uterine manipulator also can be used in some of the cases, but problem is uterine manipulator and circular stapler both cannot be introduced together. So if you are doing low anterior resection or anywhere where rectal mobilization is required in the female, you should take a bite and pull the uterus up and apply one artery forceps, it will lift it up. However, in the female, colorectal is easy, in spite of uterus having difficulty, because their pelvis is big. And one of the biggest advantages is due to the uterus, you have a uterosacral ligament and cul-de-sac which is keeping the bladder away. And when you go to this area, you have fascia adenovinis. And when you separate it, you have the big room to perform. So, if you are doing for malignant disease, you should start from the sacral promontory, and S-shaped you should reach up to the splenic flexor of colon, cut, peritoneum. As we have discussed before also, that laparoscopy start with the peritoneal incision. So here you will start peritoneal incision from sacral promontory, and then anterior to the aorta you will reach up to the splenic flexor of colon. And you have to expose the aorta, and then you will get inferior mesenteric artery. Aorta is exposed. And then you have to follow the inferior mesenteric artery, then you will get the left colic artery. And here is the inferior mesenteric vein. And then here you will go to the main sigmoidal trunk. And this you will not damage, left colic artery. And main sigmoidal trunk, once you will reach, you will clip it. After that you will start mobilizing the rectum. Rectum mobilization should be done in such a way that 5 centimeter distal to the colon and 10 centimeter proximal to the colon you should mobilize the part and from the tumor. One of the biggest drawback of laparoscopy is not having tactile feedback. So tumor you cannot palpate. So total colonoscopy and tattooing of the tumor should be done before the surgery. And you should know that how much you have to remove. You cannot take a new decision just by palpating that, oh, this is the tumor, this is the cancer. So 10 centimeter proximal. Why? Because lymphatic drain is proximal. So more metastasis is proximal. And 5 centimeter distal, you will mobilize the colon. And after mobilizing that colon, you can fire endo-GI linear stapler. And then this is the tumor, you have mobilized 5 centimeter and this endo-GI linear stapler is fired. Blue cartridge you will use. And once it is fired, up to this point, up to this stage of the surgery is called medial approach. So what is the in medial approach? Opening of the peritoneum over the sacral promontory, going anterior to the aorta, reaching up to a splenic flexor of colon, then opening the peritoneum either side, trying to find out the lymph nodes, and then sparing the left colic, clipping the inferior mesenteric main branch, and then mobilizing the rectum. 5 centimeter distal, 10 centimeter proximal, and firing the endo-GI linear stapler. Up to this point is called medial approach. After that you will apply lateral approach. In lateral approach you should mobilize from the white line of Taut. And this is a avascular line. And then slowly you will reach to the splenic flexor of colon. And then you will get all the ligaments mobilization, that is phrenico-colic, splenocolic, linorenal, all these ligaments. Lesser sac will open, tail of pancreas should be taken care of, and lower pole of the spleen also should not be damaged. And then you will take a turn to the transverse colon. And once you reach to the half of the transverse colon, then your laparoscopic part is over. This is the end of laparoscopy, colon is mobilized. This is called lateral approach. And once this approach is done, after that you have to give one suprapubic incision 3 to 5 centimeter above the upper border, this is pubic symphysis bone. And you will give a transverse incision, and either you use hand port or you use a polypropylene wound protector to prevent any contamination of malignancy or infection. And then this proximal end, which is mobilized end, you will externalize. Alternatively, transanal externalization or transvaginal also is possible. But most popular is suprapubic incision. And then you will externalize. And once this proximal part is externalized, then what you will do? That you will remove the diseased part of the colon which you have to remove, either sigmoid or descending or rectum, whatever. And after removal, in the proximal healthy area, you will put anvil. This is anvil. Circular stapler is must for the colorectal surgery, and this is anvil. So the proximal part you will drop this anvil, and after dropping this anvil, you will apply a purse string suture. This purse string suture will be applied, it is ready. And this part is cut out and purse string suture is applied. This has to be done outside. There is no any technology till today where anvil we can put in the proximal healthy end laparoscopically. And do you know the diseased colon also cannot be removed laparoscopically, because you cannot apply the stapler and put a colon in endo bag and take out. Because even if you put in the endo bag and you pull out, you have to enlarge the incision. Because colon you cannot morcellate, because it is malignant. It become a transverse arrest, it become like a ball. Am I right? So enlarging the incision is required. If you are using hand port, it is best. And in hand port, incision is 1 centimeter smaller than the glove size. If you are using 6 centimeter gloves, incision, transverse incision will be only 5 centimeter. If you are using 7 centimeter gloves, incision will be 6 centimeter. And if you are using 8 centimeter gloves, then don't use your hand, use the hand of your nurse. Because you don't have hand, you have a handa. So you use the gloves, nurse who will put the hand and she will deliver the colon out. So maximum 5 or 6 centimeter incision is enough to remove it. And then you will use this anvil. It is called anvil because it is the coming out from anus. And in the RYGV, when the same we put from the mouth, we call it orville. So this is anvil is ready. After that, this is the gun. And gun you will push it through the anus. And then there is a perforator which will perforate. And after that, this anvil will be fixed with the gun. And then your second surgeon will rotate it clockwise. And you can see anvil and gun is approximated. And then there is a safety here, press it and fire. And once you fire, anastomosis is complete, surgery is over. This is a used one, so that's why I cannot fire, it's not firing. Because it doesn't have the cartridge, so this is safety. And problem is here that gun and anvil and gun both is single use. So we cannot use new cartridge. In linear stapler also it is disposable, but gun we don't throw. And we keep on changing the cartridge like in sleeve gastrectomy or MGP. But here problem is just one firing, both is useless and you have to buy the new one. Gun also is single use because here the problem is that staples are not in the anvil, staples are on the gun. So if I will show you here in these are the holes for the staples. So company is making in such a way that they don't make separate cartridge just to make money. They put the staples in the gun part, so entire this unit has to thrown. And that is required for end-to-end anastomosis. So this is the anvil which you will put in the gun, in the proximal healthy part. And then after dropping it, you will tie a persisting suture and then drop it inside. Remember, when you are doing this part of the surgery, at that time there will be no pneumoperitoneum. Abdomen will remain deflated, insufflated has to be switched off. Because you have an incision here, so all the gas is leaked. And once you put, then you rotate this polypropylene to make it airtight again, and then drop the anvil inside. And this is the remaining rectum. Now the assistant will push the gun through the anus, and then gun will perforate by the side of the staple line, and that will do the anastomosis. There is no need of colostomy, single stage surgery, and it comes out and it is removed. So this seeing the circular stapler is very important, and we can see there are many type of circular staplers. Different companies are making, Lotus is making, Ethicon is making, Covidian is making, but the main features are same. This is perforated. And this is anvil. This is anvil holder. You will drop it into the proximal healthy part, disease part is cut out. And once it will be introduced into the proximal healthy part, then you will tie the persisting which you have already taken. And this persisting should be completely tight, completely, there is no leak. Remember, if your purse system is bad, you will not get a complete donut, just like PPH stapler. But in PPH, what we are taking? Only mucosa, submucosa. Here you have to take persisting full thickness. And after that, it is ready. Now, the gun will be pushed by your assistant through the anus, and it should perforate by the side of the staple line, not over the staple line, otherwise staple line will open. And then once you rotate, this is perforator. Perforator comes out and it will perforate the rectum. And then anvil will click, and there is a lock there, it will click. Once it is click, it cannot detach easily. And then rotate it clockwise, and automatically anvil will be pulled by the gun over the staple line. And once you reach there, this lock will open. Remember here, you will see I am taking a little back here. Just 1 minute. So if you will see here, sorry, you will see here, let me, if you will see this, no, why it is not following my command? Just 1 minute. Let me open the video directly. So, yes, if you see here, once you go here and you tight it clockwise, then there is a lock here. This lock, did you see that? And this lock will not allow you to fire the gun. Just like BPH stapler. And once this green color will come in this area, then only you will see it will automatically unlock. Just look at this point. and you see here it opens. And once it opens, that means now it is ready to fire. And you have a 2B. One is good B, other is bad B. Always this should be in the good B. This is bad B, this is good B. So this is a green color, and this green colored line should come in the good B area. So look at this. When you are tightening it, it should come in the good B here. And this is good, and this is bad. And if it is not in this visible area, then it will not fire also, because the safety lock will, and that means it is C. Sometimes what happens that you have already unlocked it, and then accidentally your knob rotated to anti-clock. You got my point? And then it disappeared. Then you have 100% leak. So before firing, always make it sure that it should go in the good B area. And then it is ready to fire. And once you fire, after firing, keep it pressed for 2 minutes. Why? Hemostasis, even in PPH stapler, because the pricking point will bleed. So keep it pressed, so that anvil and gun is due to pressure bleeding. Even if you are giving a intramuscular injection, the nurse is putting a cotton and telling you to keep it pressed. Otherwise some oozing happen. So that's why it is necessary to keep it pressed. And once it is done, now it will be rotated anti-clockwise. Once you rotate anti-clockwise, then anvil will go away from the gun, and then anvil and gun both together. Once it will go away from the gun, but it is not detached. Then both together by up, down, right, left, little bit, just like PPH stapler, slowly anvil and gum both come out together. And then you have a 2 donut. And both the donuts should be inspected, that these donuts should not be half circle. If it is half circle, that means it can leak. That means this donut should be correct 360-degree donut. Otherwise, you have to take a suture. And then you should do flat tire test. Flat tire test means you will put some saline, fill up the pelvis, and through the anus you will put some CO2. And you will see that there should not be bubble. So that is called flat tire test. And anastomotic line should be inspected. Nowadays, even in the open surgery, open colorectal also, anastomosis is done by circular stapler. Nobody is doing hand 7 anastomosis. It is not practiced. So now I am going to demonstrate you video how to do sigmoidectomy, skin to skin. Remember, this surgery is performed by Stephen D. Wexner. Let us give you one very good information. One of the best, and in my opinion the best colorectal surgeon of the world is Stephen D. Wexner. Stephen D. Wexner is the chief of the staff of the Cleveland Clinic, Florida. And he is the president of the American Colorectal Society, and he was president of SAGES also multiple times. And he is the most cited author on this earth. If you will ask the ChatGPT that maximum number of article and book who has written, this is the name come Stephen D. Wexner. And he is also one of the faculty of our institute in Florida. If you will type Stephen D. Wexner, then ultimately it will come to the World Laparoscopy Hospital also. So this is our faculty. This is our paid faculty. We are paying him, and he also take classes online for here in colorectal also. And we have one very good relation with the Cleveland Clinic, that any one of you who want to make your future, your career in the colorectal, then you can go to him without giving USMLE, and you can work under him. And for that you need one recommendation letter from here as a research fellow, because most of the time they have research going on, and you can join in their research fellow. Of course, they will not give you any payment, but once you participate in that research, and then you will get, publication will happen, always they publish, and once publication is over, after that you will get research fellowship. Many of our students has gone there, many, and some of them after staying there for 1 year, 2 years, they get job also. So what you have to do, you have to take one recommendation letter from us. You will ask he will make a recommendation letter. Once you will ask the admin, and then you can apply. Now how to apply? You have to apply at least 6 months in advance, because they have a process, and then they will give you later, and then you have to apply for visa. And the visa waiting list itself, in American visa, 6 to 9 months it takes for the visa. But on behalf of their invitation letter, you will get visa. And after that you can go and you can work under him. So if anybody is interested, you can tell me and I will give you the letter. So now we will start the video, and the first video which I am going to demonstrate you is the sigmoidectomy. So we will see the skin to skin entire video. You can see this is a benign sigmoiditis, and because it is a benign sigmoiditis, so you don't need many ports, but still you have 5 ports. And then distance between all these ports are 7.5 centimeter, and ports are put in such a way that from everywhere triangulation will be managed. Now first step is that all the bowel you have to push towards the liver above the transverse colon. So these are the omentum, a small bowel, all will be pushed towards the upper abdomen, and this will keep on pulling it towards the upper abdomen. When you pull all the small bowel, you should be careful that it should not have a torsion at the level of mesentery. So haphazardly you should not pull, carefully you should pull, taking care of the root of mesentery should not get torted. Otherwise another problem will start. And it is pulled carefully towards the upper abdomen. And above the transverse colon you will drop it. Patient bowel is empty, then it is easy. Patient bowel is distended, then it is difficult. So slowly walking over to the bowel and pulling it towards the upper abdomen. This is the first step of the any colorectal surgery, that getting rid of a small bowel. Because this small bowel will not allow you to see also. And it is pulling towards the upper abdomen. Now here we can see this is sigmoid colon and this is uterus. This one. This is uterus. So this is the mesosigmoid. Now this is the benign disease, benign sigmoiditis. You don't need to go to any colon. This is the uterus. You don't need to go any colon. Just directly you will start coagulating here, and this is ligation atlas. Ligation atlas generated is same, but this hand instrument is 10 mm. An advantage of atlas is that up to 7 mm of the vessel you can coagulate. Even the splenic artery, renal artery can be coagulated in ligation atlas. So this is ligation atlas, which is coagulating the mesosigmoid directly. You don't have to identify any vessel, any inferior mesenteric, any marginal artery. And here this instrument is suprapubic port, which is lifting and hanging the colon towards the triangle of doom, and this ligation atlas is making a mesenteric window. So we can see here, this is the colon and this is a small window is formed. So this is medial approach. Right now this is medial approach. We can see there is a window formed. After that you will drop it and again you will start lateral approach. So after making this window, now sigmoid will be dropped, and these adhesions of the sigmoid with the triangle of doom, this is uterus, triangle of doom will be freed. Now whenever you want to give infero-medial traction of the colon, always you should catch tinea coli. Because already we know that the tinea coli is the strongest part of the colon. So it is giving infero-medial traction, and this all adhesion is cutting by the simple seizures. So here seizures is used, and this is the lateral mobilization of the sigmoid. And then slowly going to the white line of taut, and this is descending colon is also infero-medial traction is given, and this is white line. So this is lateral approach. So medial lateral both is alternatively done, because here mesentery doesn't have to remove. We have to remove only colon. So this is lateral approach, and this is white line of taut, and this is descending colon. And this is avascular area, which is mobilizing the descending colon. So this is done. Further adhesiolysis at the level of sigmoidal flexor of colon. So once this mobilization is slowly going down. And always remember, fat belongs to organ and white is right. Areolar tissue plane has to be taken care of. Now again medial approach. This is uterus. By the way, this is round ligament here. And this is uterus. So now again sigmoid will be lifted. And again medial approach. So you can see how easy is the benign surgery of colorectal. And directly ligation can cook those mesentery, one jaw inside, another jaw outside the mesenteric window, and directly all these marginal arteries can be shielded by the ligation atlas. And do you know, fat medium is the best medium for coagulation. You cannot see any smoke. And it is coagulating, sealing and cutting. And it is continued. These all pedicles continue. This here will be the superior rectal artery, which is not damaged, and these marginal arteries are only cutting as nearer as possible to the sigmoid colon, almost touching the sigmoid colon. Already lateral mobilization is done here. So here the colon will be, ascending colon will be lifted up and a window is formed, this window. And this is medial mobilization now. So once it is done, after that you will go to rectosigmoid junction, and then we have to skeletonize all the fat at the level of rectosigmoid junction, because with those many epiploics and those many fat, your endo-GI linear stapler will not work. It need only colon without fat. So we will see here, these all fat, above is sigmoid, below is rectum, and this is uterus. So at this level of the junction of the rectum with the sigmoid, this is uterus. This is uterus is touching, but no problem. Here is the uterus, this one. So at the level of rectosigmoid, skeletonization is getting performed. All these fat is getting separated. This is uterus. The advantage of ligation is that outer surface is completely cold, because it has an insulation in between the outer surface and inner plate. So you can see it is touching the uterus, but uterus will not burn. This is uterus. And this is what? Sigmoid. And this is what? Rectum. And this is skeletonized. All the fat has to be removed. Why? So that your stapler should make a good B. It should not make a C. And it is done. This is uterus. Below is rectum, above is sigmoid, and it's over. After that, you will bring endo-GI linear stapler and fire. Here is the uterus is lifted, this is the rectum going in the cul-de-sac. And now here, this is the skeletonization process is complete. We cannot see any fat at that junction of staple line. And then blue cartridge you will use, and you will rotate and articulate your stapler. That's why staplers are called roticulated. So this is the stapler. You can see blue cartridge, and it is fire. Below is rectum, above is sigmoid. This is sigmoid, and this is rectum, and it is firing the stapler. Because it can articulate, so it will be completely transverse firing, and it's done. Now rectum is separated from this, that's why it's called roticulated. Roticulated means rotating and articulating, both the functions are there in the stapler. So these are also called roticulated. So it's done. And now sigmoid is detached from the rectum. This is what? Rectum. And this is what? Staple line. This is staple line. And this is rectum. And now it is easy to do further lateral approach. Why? Because distal end is free. Because it is detached from the rectum. And now this is the further. Do you know benign sigmoiditis is the first surgery which in colorectal surgery you should start. Malignant should be done according to the colorectal surgery is a multidisciplinary approach, and malignant you should done never in the solo practice. You should done in tertiary care because you need radiotherapy, chemotherapy and multidisciplinary approach. And it is recommended that before doing malignant, at least 50 benign surgery you should do in colorectal. So the first surgery to start in colorectal is sigmoidectomy because it is the most common and it is easy. Now we can see it is at the level of splenic flexor of colon. And once you reach there, you have the omentum, you have the phrenico-colic ligament, splenocolic ligament and lino-renal ligament. And this is just a seizures, and you should remain as near as possible to the colon. And once you reach to the transverse colon, all the omentum of the transverse colon also you have to separate. These are the omentum of the transverse colon which is separating here in this area. And it's done, reaching to the half of the transverse colon. After that, you have to decide that what you have to remove and what you have to keep. You can see throughout the surgery till now there was not a single drop of blood come out. So if you see here, this right side is sigmoid, left side is descending colon, and this ligation will split this mesentery because right side has to remove, left side has to keep. So it will split the mesentery directly. And it is splitted, and this is sigmoid, and this is descending, and it's done. Now laparoscopy is over, and now this is waiting for its exteriorization. Laparoscopy is finished. Now open surgery starts. This is all about laparoscopy, what you have to do. That you have to make a sigmoid, mesosigmoid, one medial window, and then keep on doing medial mobilization, lateral mobilization, and transect the rectum and sigmoid junction. And after that, mobilize it up to transverse colon, and now open surgery. So let us see how to do open. This is the pubic symphysis. This is linea alba. This is inguinal ligament. Just 3 centimeter above, this is a transverse incision, and this is a wound protector. This is a plastic wound protector. And this wound protector has 2 silicone rings. One silicone ring is outside, another silicone ring is inside. And through that, this wound protector, now the sigmoid colon will be pulled out. You will put a grasper at sigmoid. This is the inguinal ligament. This is the anterior superior iliac spine. This is the mid-clavicular line. This is the midline linea alba. And here is the pubic tubercle, and this is the suprapubic. And now this is a ring, silicone ring inside the abdomen, and this sigmoid is going out. And it is pulled out, and it's out. And this is out. And this wound protector is not allowing the contamination going to the abdominal wall. After that, this is the disease part of the sigmoid, and this is descending colon. So you will decide that at which point how much I have to remove, and then save all the fat of this part. Do you know why? When anvil and gun will be fired, in between anvil and gun, any of these epiploics or mesenteric fat should not trap. Otherwise, it will do anastomotic leak. So you should, all these fat you should shave out, and it is out. And after that, once it is shaved, and this side is sigmoid, this is descending colon. This is descending, this is sigmoid. And once it is shaved, after that there is a beautiful instrument that is called purse string applicator. This is sigmoid, this is descending colon. And this all fat is shaved carefully, that serosa should not burn. And this instrument is called purse string applicator. In this instrument there is a hinge like that, and once it hold, it will trap the bowel, and there is a needle, you will pull it, and automatically all around purse string is applied. So this is a purse string applicator, this one. Manually you don't need to apply. However, in India we apply manually because this instrument itself is costing 25,000 rupees. So you will apply this purse string applicator, and it is done. And do you know what is this? Sigmoid. And what is this? Descending colon. Now it is sealing, and then this is scissors, and scissors is cutting out the sigmoid colon, and sigmoid is detached from the descending colon, and it will be sent in a specimen bag for biopsy. And now purse string is already applied. And now this purse string you will open, and you will drop the anvil into that. And this all is over the wound protector, and this is laparotomy wound. And at that time when you are taking the colon out, cutting the sigmoid out, putting the anvil, there is no pneumoperitoneum, laparoscope is out, all the instrument is out, only cannula is there. And it is open part of the surgery. And now this is lumen of the descending colon is open, and this anvil is dropped. And after dropping the anvil, you will tighten the purse string. And purse string should be nicely tightened around the shaft of the anvil, so that there should not be any leak, and it is done. And then it is dropped inside the abdomen. Now it is dropped. And once it is dropped, now again laparoscopic pneumoperitoneum is done, and again laparoscopy is started. After that, this is what? Uterus. This is what? Ovary. This is what? Tube. And here is the rectum. And now the assistant surgeon is pushing the perforator through the rectum by the side of this staple line. If it will be pushed over the staple line, all the staple opens. Just like in your shirt, where the stitch is there, one stitch is open, all will open. So just you have to perforate by the side of this staple line here. And this is perforating the rectum. And after that you can remove these perforator. However, nowadays in the new perforator, there is a metal perforator inbuilt. There is no plastic separate. But in some of the model, plastic is separate. Now this is the anvil, and this is gun. So anvil will be put in the gun, and it will give you a click sound, because once it attach, it will automatically be fixed. So I will show you here that when it attach, it gives you click assay. And now it will not detach so easily. It is holding, you can see. I have to apply force to detach. So you must face this is yellow color, and this yellow color should come in this green color, and it will give you click, click. That green and yellow is touching together, that means it's okay. So it will go like that, and once you will push this sound will come. And then you will start, and remember, at a time when you are tightening, it should be perpendicular. It should not be longitudinal. It should be always perpendicular. And once after firing, it will keep on slowly, and then we can see, and will come near the gun, rotating by clockwise. So here we will see that it is coming, and this is uterus. And then anvil has come near the gun. Now, once you will fire, then you will put some saline, and then slowly gun and anvil come out through the anus. and then you will inspect the donut. What is this? Descending colon. And what is this? Rectum. This is rectum, this is descending colon. And you can see complete 360-degree donut is there. There should not be half moon shaped. And now this is flat tire test. Patient head should be up and at least 500 ml to 1 liter saline will be put in the pelvis and the rectum will be distended to check that there should not be any bubble coming out. So that is called flat tire test is going on, and then surgery over. So this way sigmoidectomy is a easy surgery which can be performed nowadays with the laparoscopy, and most of the time it is bloodless surgery, and if you will use the correct instrument and correct staplers, then there will be no problem. Low anterior dissection also I will discuss later when we will discuss, if time permits I will discuss, but that should be performed in multidisciplinary approach. However, those videos are there in your member area. This month only Stephen is not taking lectures, but if you will put in the Google that lectures of Stephen D. Wexner, then this month he is not taking because he is having some other engagement. In the Google, if you will go, these all lectures are of Stephen D. Wexner. These all lectures are master classes which is in our hospital. So these all lectures he is taking for our students.
Good morning. How are you?
Good, thanks. How are you?
I'm okay. Thank you very much.
Good. I have prepared for now, August and September, sort of a three-part video presentation on J pouches. I thought today I'd go over some of the basic background for the J pouches, and then we're going to go over some more complex things the next two times, if that's okay with you.
Yes, it's fine. Thank you.
Okay, so let me open my presentation.
So this is his lectures and videos.
You can see it was relatively easy taking the specimen out, generally within 1 centimeter of the...
So the pouch, and how do we manage them and follow the patients? Pouchitis or...
This is an entire next two lectures is going into problems with pouches and how to manage them, because...
So these all lectures are there in your member area, and if you are interested in colorectal, then you can go in the detail of J pouch or complex surgery or the different type of other colorectal procedures. So, complication of sigmoidectomy is wound infection, anastomotic leakage, bleeding, ureteric injury, cardiopulmonary failure, pneumonia, and renal failure. That's why it must be done in a multidisciplinary approach, where you have all the department working together, because most of the patient will be elderly, and those elderly patients need a lot of support. So there is a very good lecture that multidisciplinary approach of colorectal cancer, and this is also very good lecture which is present in our member area, and you should download this video. And this is also of the Stephen which he has taken for
Hello,
our
Prof. How are you?
Good, thanks. How are you?
Yes, I'm okay. So you are seeing.
So this is the lecture
Be more
regarding
distal.
that how to deal with the colorectal,
Absolutely.
and just I
see
am
all
taking
of
a little
us?
back.
Yes. I can see a large room of people. I'm just facing me. We're
So this,
happy to do so, and perhaps I'll see some of you when I'm in Chennai in a couple of weeks for our fourth.
so here this is the lecture, the importance of
Okay.
multidisciplinary
Can you
care
see
in
my
rectal
slides
cancer
now?
management.
Yes, we can see the importance of multidisciplinary care of rectal cancer.
Exactly. So that'll be the topic for my first lecture in this series, and it's my privilege and pleasure to be with you today. And at the center of multidisciplinary care, of course, is the patient, but many other specialties are involved in rectal cancer care.
So this is important that whenever you want, and you know, colorectal surgery is a completely different subspecialty. If you want to become a colorectal surgeon, then you have to dedicate and you should focus in the department of colorectal. It is not like that we are doing the, cholecystectomy, hernia and the other bariatric and then becoming together colorectal, not possible. If you want to dedicated colorectal surgeon, then you need to go in that branch and dedicate your entire life into that. However, simple rectal prolapse and sigmoidectomy, as a general surgeon, you are allowed to perform. So these are the complications which we should keep in mind. So is there any question?
So if you don't have a wound protector,
Wound protector is only 2000 rupees. In wound protector, there are two silicone ring and there is a polypropylene. So it is not expensive. Cost of hand port is 40,000. And if you don't have a wound protector, you can use one polypropylene, simple polypropylene, and split it, same which we use cellophane dressing, same type of polypropylene, and you can put a portion inside. And suppose you don't have a wound protector and you are 100% sure that this is not a malignant case, it is a benign, then you can do without that also.
sir, also when we put the angle proximally, you have to rotate the wound protector to create pneumo again.
No, inside is ring and ring is pulling up, and outside polypropylene you rotate and clamp, gas stop leak. So it is easy, but incision will be still there because some region you want to put your hand or extract again untwist and then it opens. So just you have to keep on rotating it and then polypropylene will rotate and then clamp it. That's all. So it is a circular stapler generally is not required for a small bowel except if you are doing J pouch surgery, in which you have to make a rectum out of the small bowel. Am I right? In that you are using for the terminal anastomosis. Circular stapler has only problem is that one end has to come through the anus. Am I right? So in a small bowel, always side-to-side anastomosis. Even if the right colectomy you will do, you have to do side-to-side anastomosis. Circular is only required for the terminal end of the GIT. Like circular is also used in the RYGV. From the esophagus you can put anvil. That is also called orville. And then gun goes and then you can do anastomosis for the gastric pouch. From there you can do circular stapler. So either from the mouth or from the anus. In the small bowel, side to side. No need of circular stapler.